Thank you so much for joining our Georgia Recovers December webinar titled Merry, Bright, and Informed, Current and Emerging Drug Trends and Treatment Modalities. And if you want to start off with dropping your name and organization in the chat, we'd love to see who's joining us this morning. So hopping right on in. Our agenda for today, we will start with some welcome and housekeeping. We will do a brief overview of the Georgia Recovers campaign. I'll introduce our lovely speakers, get into our presentation, and then we'll wrap up with our Q&A section. A few housekeeping rules. The webinar will be recorded and a copy of the presentation will be available on the Georgia Recovers website. All attendees will be muted. Please use the Q&A panel on the bottom of your screen to ask any questions. The chat will also be available, but just for general commentary. So if there are any questions that you would like to be answered during the Q&A portion, please use the Q&A panel. The interpreter will remain spotlighted throughout the webinar. To adjust your view and see all speakers, panelists, just click the view in the top right corner of your screen and then select speaker or gallery. Also, the users can also select a side-by-side view if you choose to. Feel free to use the stream text link to access the live transcription of the webinar, and Ashley will pop that in the chat for easy accessibility. So on to the Georgia Recovers overview. So Georgia Recovers is an evidence-based public health campaign aimed to reduce the prejudice and discrimination that's associated with substance use disorder in Georgia. So the campaign is brought to you by DBHDD and builds off of the pivotal work of the Georgia Council for Recovery. So a few of our objectives include increasing knowledge about substance use disorder and that recovery is not only possible, but probable. We want to improve attitudes towards those living with and or in recovery from substance use disorder, and also strengthen the capacity of stakeholders, including organizations and individuals that are already responding to the crisis. So we have 3 pillars of work: community connection, story sharing, and education. So regarding community connection, we partner with different organizations that are on the ground in order to expand our reach, and also just provide points of collaboration throughout Georgia as well. We also have our Community Impact Committee, our CIC, that guides the direction of the campaign. And a few of you are here today, so thank you so much for joining the webinar. Story sharing is the bread and butter of our campaign. So we collect stories of recovery and allyship, and we share these stories across our social media channels as well as our website. So last but not least, the education pillar. We seek to change the attitudes by promoting messaging that speaks to hope and recovery. And we also host monthly webinars such as this one to shed light on topics that are related to substance use disorder. Feel free to connect with us on Facebook and Instagram to just stay updated with all of the great things that Georgia Recovers has going on. And if you want to become an official campaign partner, fill out the community partner form as well. Ashley will also drop those links in the chat for accessibility. And moving on to introducing our speakers. So first and foremost, we have Dr. Colleen Lane. Dr. Colleen Lane completed her dual residency training at Detroit Medical Center, Wayne State University, in both internal medicine and pediatrics, and is board certified in addiction medicine. While working at Whitman Walker Health in DC, she dedicated her practice to LGBTQIA+ affirming care, treating individuals living with HIV, and particularly focused on those suffering from substance use disorders. Now, as the medical director of addiction medicine at Corewell Health, Dr. Lane has brought the lessons learned by the HIV community on best practices for harm reduction and low barrier access to her current work in addiction medicine. Modeled after HIV same-day antiretroviral START programs, Dr. Lane founded a low-barrier walk-in clinic at Corewell Health's addiction clinics for high-risk substance use disorder patients. In the first 2 years, the walk-in program has successfully connected over 800 new patients in addiction specialty services the day that they were ready to be seen, which is really, really awesome. Dr. Lane is a true physician advocate, and alongside her clinical work, she is a primary investigator on an international clinical trial, serves on her county's opioid task force and overdose fatality review, volunteers as a board secretary for the Grand Rapids RED Project, which is a large harm reduction program. Oh, apologies. And then I'm having a difficult time reading the last line. But yes, thank you so much, Dr. Colleen, for joining us today. We're super excited to get into the presentation. And next we have Dan Wickland. Dan Wickland is a doctoral candidate at the University of Cincinnati College of Nursing and serves as the nurse educator for addiction medicine and for Corewell Health. Dan works primarily with the system level opioid stewardship team to provide subject matter expertise and guide the clinical practice and policy development for controlled substances. Dan comes from a background of critical care and HIV medicine and utilizes the lessons learned from these areas to improve access and equity to substance use disorder treatment. In his time here at Corewell Health, Dan has worked to develop the nurse-led walk-in access to substance use treatment available at all Corewell addiction medicine offices, and continues to set immediate access to care as the emerging standard for substance use. Beyond his clinical role, Dan serves as adjunct faculty, educating the next generation of nursing professionals, emphasizing the importance of harm reduction and self-determination in nursing science, and travels across the nation to speak on utilization of nurses to expand health access points for disadvantaged communities in efforts to address health inequities. So thank you so much, Dan and Dr. Colleen Lane, for joining us today. I'll go ahead and stop sharing my screen and pass it over to you all.
Thank you so much for those wonderful introductions. I am here with my partner in clinical work and policy work, Dan Wickland, and we are really excited to talk to you all about a lecture that we call Drug Myths, Trends, and Opportunities to Intervene, but I love the Merry, Bright, and Informed, so we might have to borrow that in the future. Today, really what we're hoping to cover are just describing some general knowledge about the drugs that are in our community and in our country so that you can feel comfortable talking with your clients, with your patients, family, and friends, so you're informed about what's out there. Dan is also going to cover some new and emerging substances, things that you've probably heard in the news or also heard from friends or family members. We're going to review some drug trends, especially some trends, unfortunately, in drug poisonings and overdose. We're hoping to cover some myths and dispel some myths around substances and use in general. And then we're really going to focus on describing opportunities to intervene, what in practice looks like, and really hopefully answer some questions that you might have about what substance care in addiction medicine looks like. So there's a lot of substances, a lot of drugs that are out there in our community. On this slide, I've just kind of highlighted a few of them. And bold are the ones that we have time to kind of delve into in today's lecture. Please feel free to drop questions into the chat. We really, if this was a smaller group, like to make it informal and collaborative. We want to make sure that you're getting your questions answered because there is a lot of information out there. So we want to make sure this is high yield. The first substance that I really like to talk about is something that is pretty common. It is also legal. Depending on who you're talking to, it's either pronounced kratom or kratom. So kratom is a really interesting substance. It is a traditional substance that is native to Southeast Asia. And when it was used in its traditional sense, it was typically brewed into a tea, or people would use the leaves of the plant to chew or steep into a drink. And traditionally, day laborers would use this substance because it gave them a little extra pep, a little energy. In fact, there's reports of military members from Thailand who would put kratom leaves into cola products and drink them in order to become bold and fearless in their work. Really unfortunately, Thailand started to recognize pretty early that this substance was something that could be misused or abused. So they started to actually put in regulation around the use of kratom. And in the 1940s, they passed a law, the Kratom Act, making it illegal to plant this shrub or this tree. And then in 1979, Thailand actually classified kratom as a narcotic, so an illegal substance, and they put it in the same category as marijuana. Now, the interesting thing about kratom is that here in the United States and in most of the Western world, it is not a regulated substance. This is a picture from when I was in North Carolina, just walking down the street, and you have probably seen similar sandwich boards that are advertising kratom in teas, an additive to your coffee. You can buy it as pills or buy it as a powder. And what we know about kratom is that certain metabolites seem to have an interaction with our opioid receptor, the mu opioid receptor, especially at higher doses. So at lower doses, people are getting that stimulant kind of midday coffee or green tea effect. But at large doses, and we're talking about over 5 grams, so pretty significant amounts per dose. And people will talk about taking that 5, 6, 10 times a day. People can get a sedative narcotic-like effect. So what we're finding is that people are using kratom as an adjunct to an opioid, maybe as a way to self-taper themselves off opioids, or as a substitution, thinking that this is something safer. Because again, it's not illegal here in the United States. What we know is that kratom at those very large doses can have some negative side effects. So people are reporting things like upset stomach, agitation, fast heart rate, even hallucinations. We haven't seen kratom itself be a cause of fatal overdose or drug poisoning. If, unfortunately, someone has passed away from an accidental overdose and kratom is there, it's usually part of other substances that were found in that person's system. So the next substance that I like to talk about is marijuana. So when I talk about marijuana, what I really, my line is, this is not your mother's or your grandmother's marijuana. What people are getting in dispensaries today is extremely potent. So for folks that may be returning to use or who are novice users or new users, it can actually be overwhelming to walk into a dispensary. Here in Michigan, it is legal recreationally. So we have dispensaries kind of all over. And you walk in and there's jars of dried flower. There are edibles that look like gummy bears or Oreos. And so it can be overwhelming to know what you're taking, what the potencies of these different products mean. And so what is really important to know is that in the 1970s, 1980s, the psychoactive part of marijuana, meaning the part of the plant that causes the euphoric effects. When you went to wherever you were purchasing your product, it might be about 25% THC. Nowadays, what people dispensaries can be as high as 90 or 95% THC. So people can really accidentally overconsume and have negative side effects. So the intoxication from marijuana, kind of the effect people are looking for, is to be talkative, to be social, to be the life of the party. When we go beyond that and that THC level starts to really go up and accumulate, people can start to have things that look like panic attacks. They can be anxious, feel like they can't catch their breath, feel extremely paranoid. And in some cases, especially with elderly folks, they can get dizzy and fall. So that could be a safety issue. One of the pictures here we like to point out the bag of Doritos. One bag is Doritos that is not laced with THC, and the other bag, you can see on the left-hand side, has a very small emblem that says THC. If you were young, a child, or maybe not looking for that little warning label, it's actually very easy for people to accidentally consume THC. And this can be a safety issue, especially if there are children in the family. So those products that look very similar to commercial products, now in certain states like California and Denver, Colorado, have been made to be illegal. It has to be very obvious to consumers that these are THC products so that someone doesn't accidentally get exposed when they're not intending to. The next slide, we talk about a different way to consume marijuana or THC that's called dabbing. You have probably heard of this. And what this is a very concentrated form of cannabis. So that little jar at the top has a resin, a concentrated resin that is sometimes as potent as 90% THC. But what's important to know is that the person in this picture here who is dabbing, so who is inhaling that concentrated THC, it looks very similar to a vape pen. So something that would have a lot less potent form of marijuana in it. So unfortunately, we have had cases of people who maybe are at an event or out with friends and are past this pen and they think it might be lower potency THC, and it's this very concentrated tab. And that's a situation where someone can have an accidental exposure to higher potency marijuana and have those bad side effects. So important to know the difference between the two and to know that that is a product that is out there. So the next thing we're going to talk about are other really common substances. These whippets, poppers, inhalants that kind of have a bunch of different names. These are common household items. So these are noxious, compressed chemicals that are found in things like a whipped cream container, computer duster. They're also sold in those little bottles, and on the next slide, that are in bottles of nitrate that are for leather cleaner and other things. What people are using these for is a quick kind of out of body experience high. So if someone inhales this chemical, for about 30 seconds, they have this rush. Some people describe it as a head rush. They're floating, feel like they're out of their body. And then they kind of come back to themselves after about 30 seconds or so. What is happening is that the chemicals are causing a relaxation of that person's blood vessels. So there's a drop in the blood pressure or the drop in the blood being delivered to your brain. So if somebody uses these chronically, you could see how low blood pressure and low blood delivery to critical organs like the brain, the kidneys, other organs, you could have damage over time. These chemicals are oftentimes mixed during a practice called chemsex, which is simply using a type of substance or any type of substance during sex. And it could be poppers or these inhalants. It could be other substances. Another common one we're going to talk about is methamphetamine. But the reason that whippets or poppers are used during chemsex is that it also relaxes smooth muscle. So for someone who's having anal receptive sex, it makes that much easier. Something to know is that mixing inhalants with some other substances that may drop your blood pressure, like alcohol or sildenafil, otherwise known as Viagra, can lead to a very dangerous drop in blood pressure. So it's something to talk about with people and make sure they know the risks of. Chemsex is actually something interesting. In the HIV world that Dan and I have a background in, this is a known risk factor for STIs or sexually transmitted diseases, something we really have been talking about since about the early 2010s. It was a term first coined in the United Kingdom. And what has really caused chemsex to become much more pervasive or popular is our app hookup culture. So apps like Grind, Gruff, Squirt make it easier to meet up with somebody and to have a message beforehand, or even seek out somebody specifically if you want to mix chemicals or substances with sex. So there's actually a article that was published that showed young people in the MSM, so men who have sex with men community, sometimes are reporting that they've never had an experience of sober sex, meaning sex without a chemical on board. So really important to talk about with our patients and our family members and friends. So the next kind of group of substances that we're going to talk about are stimulants. I think when most of us think about a stimulant, kind of the archetype or the one that comes to mind is cocaine. Cocaine is a plant native to South America. It is labor intensive. You have to grow it, you have to harvest it, you have to process it. Traditionally, cocaine or coca was used as a tea or also chewing help with energy, and it also helps with altitude sickness. So in some of these countries with high mountains, it was a natural remedy for altitude sickness. When it is used as a powdered substance or a rock substance, people get a very energized high or euphoria, feeling like they have all the energy to do whatever they want, to be a social butterfly. All over body excitement is another way that people will describe it. An overdose from cocaine can cause blood vessel damage, heart attack, and also can cause constriction in the small airways of the lung. So it looks very similar to a heart attack. Now, the interesting thing is, like I mentioned, cocaine is very labor intensive to produce. So kind of pre-COVID in the 2010, 2015 or so, we started to see the market shift toward a cheaper, easier to produce stimulant called methamphetamine. And really, during COVID and then now post-COVID, methamphetamine far and away is the stimulant that is most available on the market. And it is because it is easier to mass produce. It is being able to be sold for cheaper and much more pure. So people can experience a really intense high for a very small amount of money. So there's a couple statistics on here that I really think help illustrate this big shift that happened. In 2018, here in our state of Michigan, about 240 home meth labs were seized, meaning people who were making their own methamphetamine out of chemicals that they got from the store, the gas station. By 2019, that number was down to 28 meth labs. And the reason is, again, meth is so easy to mass produce that the vast majority of methamphetamine that's on the market now is coming from outside of the country, mass produced by large organizations, meaning that this is unfortunately extremely pure and highly addictive. So it's really important when we talk about methamphetamine, how people are using it and what it's doing to their body. Methamphetamine can be consumed in many different ways. It can be smoked, it can be swallowed, it can be injected. Unfortunately, what we're finding, or people are reporting to us, is that they aren't necessarily starting with the lower risk ways of using this substance, like smoking it or sniffing it or swallowing it. What we're seeing is that many people are reporting that they're going straight to injection because it produces such a rapid and intense euphoria. So methamphetamine, what it does, or what people are seeking when they're using the substance, is again that euphoria, that feeling of just intense happiness and joy. People are awake, they're alert. We have a lot of our patients in our clinic who are unhoused, and so they'll talk about using methamphetamine as a safety tool to stay awake at night. The chronic effects of methamphetamine, unfortunately, can lead to things like paranoia, confusion, hallucinations. There's a condition where people will feel things crawling like bugs on their skin. That's called Morgellons. So it really is a chemical or a substance that can cause pretty severe effects and chronic effects on the person who's using. What methamphetamine is doing at kind of a neural level or a cellular level is we'll describe it to patients as a dopamine bomb. So methamphetamine is sending a signal to your neurotransmitters to just dump as much dopamine out of your system. And dopamine is our happy hormone. It's what gets released if we see a picture of a puppy or we have a bite of a chocolate cake. But methamphetamine just says, dump everything you have into the neural synapse, and then it blocks your cells, your neural synapse ability to take back dopamine. So you're depleted and your reservoir is completely gone. And then methamphetamine is neurotoxic. So it destroys that cell on its way out. So there's no ability to make up the difference. Your factory is closed. So what's happening is folks are living with this inability to feel joy without methamphetamine. So you get trapped in this cycle where another word for it is tolerance or dependence, where I like this graph that shows at a baseline, someone who has never been exposed to methamphetamine, their baseline dopamine level might be about 100. When they use methamphetamine and they have that rush of dopamine, they might get it flooded up to 900, but because their reservoir is depleted, once the methamphetamine is gone, you can see that their new baseline is much lower than when they started. So in order to feel the same effect of the drug, people need to either use more of it or use it in a more intense way. So instead of smoking, maybe it's injecting, and maybe it's injecting more. Maybe it's mixing the drug with sex, another mechanism to release dopamine. So the next slide really shows or illustrates again at a brain level what is happening. And these scans show, some of the language in here is old because these scans are from a few years ago, but somebody who's never been exposed to methamphetamine, the red illustrates dopamine activity. So all of these people were exposed to the same stimulus. I think it was something like eating a chocolate cake. So you can see somebody whose factory, whose internal ability to make dopamine is not damaged, that red is lit up. The next level down is someone who has 1 month free from methamphetamine. They're stimulated with something that typically would give us joy, and their red factories, that dopamine level is 0. It takes, the next slide down, a year, over a year, 14 months, for your brain to heal and for you to be able to start to release dopamine on your own again. So the good news is that you can heal from the substance. The challenge is it takes over a year. So telling someone you have to feel nothing, feel no joy, feel in medicine we call it anhedonia, just kind of this sense of gray, and months while your body is healing is really difficult. This graph over here shows another way, and oftentimes we'll show this to patients, that illustrates that dopamine bomb compared to any other stimulus, cocaine, food, alcohol, methamphetamine is off the chart. So what do we have in order to help people kind of get through this, get through stimulant use disorder treatment? We don't have a medication that can make this process happen faster. What we do is support people through this process with things like therapy, support groups. Really, the thing that has the best evidence for it is something called contingency management, or giving people rewards for agreed upon behavior. So it might be coming to your appointment on time. It might be having a urine drug screen free from methamphetamine. And that helps kind of just stimulate a little bit of dopamine activity. And it has the most evidence for treatment. So the other things that we want to make sure we're doing as a part of treatment is paying attention to any of the comorbidities or things that can happen to a person who is using these substances. So in the case of methamphetamine, specifically, we want to ask about the risks of chemsex. So again, mixing that substance with sexual activity. And what we know, this is an article from 2020, someone who is mixing sex and substances can have a lower level of inhibition, meaning they might be more likely to make choices that are high risk, such as foregoing condom use, having more than one partner. And this places them at a higher risk for things like sexually transmitted infections, like HIV, hepatitis C, or other STIs. And then the next section, when Dan talks about treatment, luckily we do have some options like PrEP and offering screening and testing for these infections. So sorry, just waiting for the next slide to come up. All right, so the next group of substances we're going to talk about are opioids. And kind of like cocaine, when you think of a stimulant, the archetype of an opioid, when we think of that, is really heroin. So when people think of the illicit opioid market, they think of someone who might be using or consuming heroin. Most heroin is manufactured or produced in Afghanistan, and it is a labor-intensive process. So the picture here is showing a poppy plant that has to be lanced, that resin has to be collected, and then it has to be processed into heroin and then shipped. Very similar to what happened with cocaine is that even pre-COVID, we started to see the market shift toward synthetic opioids, which were easier to manufacture. But during COVID, this process really shifted quickly. So with land borders closing, laborers weren't able to get into Afghanistan to help actually lance and harvest the poppies. And then it was hard to ship out because of land border and other transportation shutdowns. So what the market really shifted to here in the United States and Michigan, as well as across the country, was the chief illicit opioid that we are now dealing with is fentanyl. The reason that this is important is that fentanyl is extremely potent. It can be up to 50 to 100 times more potent than heroin. It also does not last as long as heroin. So people are dosing themselves multiple times a day in order to stay out of withdrawal, in order to keep from getting sick. So this is a really vicious cycle that people are trapped in. The other important thing to know about fentanyl is that it is now being sold not only just as a powder, but as pressed pills, meaning things that look like they came from a pharmacy, things that look like maybe a Percocet or an oxycodone, which are two brand names you might be familiar with. So someone might think they're making a safer choice. We unfortunately see this a lot with young folks, with adolescents, who say, you know what, this is a pill. I trust this because it probably came from a pharmacy or was prescribed by a medical provider. And unfortunately, what's happening is that many of those are fake and are fentanyl plus fillers pressed to look like something that came from a pharmacy. So what to do is to make sure they're checking their substances with fentanyl test strips. I have a picture of a chocolate chip cookie on here because just like a chocolate chip cookie, the entire cookie is not made up of chocolate chips. So if the chocolate chips are the fentanyl and the cookie part is the fillers, you could break off a little piece of that cookie and miss a chocolate chip. So when you check it, it could be negative for fentanyl. And unfortunately, you can see that there's chocolate chips or fentanyl all over that. So what we tell people to do is crush up the entire pill, mix it, and then check that mixed up powder. So that makes sure that you're not missing the potential for those chocolate chips or those fentanyls to be studded throughout that pill. So unfortunately, what this is leading to nationwide are an increase in accidental overdose deaths. And really the new nomenclature that we're talking about is drug poisonings, because people are being exposed to fentanyl unknowingly. And so that truly is a drug poisoning. So really, the things that in my last few slides I wanted to make sure we all knew is that these drug poisonings and this epidemic is not affecting everyone the same. So according to some data from 2018 to 2020, people who are suffering deaths from the opioid epidemic are mostly people of color. So really the top groups are those who are Native American, African American or Black individuals, and Latino people. You can see on the breakdown of these percentages that white or Caucasian individuals are much less likely to die of a accidental drug poisoning compared to their other counterparts. So this is unacceptable. And really what this means is that we as addiction specialists are not reaching everyone equally. And when we break down this data even further, we can see that African American or Black men are dying disproportionately compared to any other group. So their rates are now on par with Native American individuals for the most likely demographic to die of a drug overdose. And you can see this data from 2015 to 2020. African American men is that dark blue line, and it has really just exponentially increased. And there are several reasons why the authors of this article propose that could be a cause of this. And what we do know is that people who are on the lower part of our social hierarchy tend to be exposed to fentanyl more often because their drug supply is more contaminated. So if you can afford higher prices of substances, you tend to have things likely to be contaminated with synthetic opioids like fentanyl. There's also less access to healthcare in general. And we know that African American and people of color are incarcerated at much higher rates, which also leads to a lot of these outcomes. What we know, and this is my last slide before I hand it over to Dan, if we change nothing about how we are approaching this opioid epidemic, we are going to see 1.2 million deaths in the next decade. And the people who will be suffering those deaths are our neighbors of color, African American individuals, Latinx, and Native Americans. So we've got to do it differently.
So I'm going to transition and talk about kind of new and emerging substances on the drug market and on the national scale. Probably the one that most of us have heard about at this point, there's been a lot of press and media about this, is xylazine, also called tranq. So xylazine historically was approved in veterinary medicine. It was developed in the 1960s and trialed as a blood pressure medication for humans and was found to cause profound sedation and was actually leading to total cardiac arrest. So it was not approved for humans, approved for large bovine-esque animals, and that's where we really saw it. It's important to note that it's not FDA approved, or not monitored as a controlled substance. It is pharmaceutically manufactured and purchasable by veterinarians. What we were seeing was the introduction of xylazine opioid supply to mimic traditional heroin. So as Dr. Lane had mentioned, fentanyl has a relatively narrow therapeutic window and euphoric window, more importantly, for illicit use. So if I can make my fentanyl like heroin, I'm getting that euphoric experience for a longer period of time, it's going to feel better. So there is incentive to kind of mimic traditional heroin with fentanyl, but fentanyl, as we've discussed, is a lot easier to ship over our borders. That being said, we did see early reports of this in Puerto Rico in the early 2000s. A lot of the information I'm going to be discussing is anecdotal. This evidence is unfortunately based on decedents or non-traditional or non-medical research platforms. We'll talk about those in a couple of slides. But what is interesting is the CDC had released new information that basically found that xylazine contamination has largely increased. So we started to see this back in 2015 in Philadelphia. Philadelphia was kind of the first canary in the coal mine. In 2015, about a third of their total fentanyl supply had contamination or co-detection of xylazine. By 2018, it was completely 100% co-detected. Unfortunately, we're now seeing this as a national issue, and the data is supportive of this. We've seen a co-detection rate increase of nearly 300% in CDC data alone. It's important to note that this data point did only come from 21 jurisdictions that were trending. But again, extrapolating this to the nation, this is a growing issue, and we're going to be dealing with this in the coming years. The concern with xylazine is, while I hesitate to use the word therapeutic, but the intended effect is to prolong the euphoric high. That being said, it has effects on blood pressure and blood return to the organs. So what we are seeing is these wounds that are developing basically because I'm causing an injection use. I'm causing a wound at that site, and I'm decreasing the blood return and the blood supply to that site. That wound isn't healing within a reasonable time frame, and secondary infections, which is leading to the significant wounds that you can see on your screen. Some of these wounds are so extensive that it's actually leading to limb loss. Dr. Lane and I do have a couple patients who have lost limb due to xylazine co-use. The unfortunate part of this too is there's not a lot that we can do besides prevention. So we like to talk about how an ounce of prevention is worth a pound of cure. So getting word into our communities is the biggest thing we can do. Talking about administration techniques, making sure that people have access to clean equipment and work, making sure that we're not introducing bacteria into these wounds once they've developed. So again, cleaning them, but making sure that we're not picking or spreading our infections into the wound bed itself, providing clean wound supplies to our patients, and then really community education and awareness. We're fortunate to have a harm reduction organization that does drug testing. So making sure that our supply is at least awareness of xylazine in the supply itself. What is interesting, and I was just reading an article this weekend, is lidocaine. So the things that we use to kind of numb our teeth in dental procedures is a common cut with fentanyl. It doesn't provide any effect, but it provides bulk to fentanyl supply. Lidocaine will cause a false positive in point of care testing for xylazine. So just being aware that our drug testing supplies, and there are wonderful point of care tools, but they're not 100% foolproof. So is there utility to them? Yes, but drug testing using mass spectrometry is always going to be recommended. And we are seeing that into our communities. Zaza, or tianeptine, is a tricyclic antidepressant approved in Europe for antidepressive-like effects. That being said, when it was originally published for the FDA to review, it did not meet safety profile, so thus was not approved in the US. That being said, it is introduced in the US via the kind of roundabout way of dietary supplements. So similar to you buying vitamin D or a multivitamin over the counter, you could theoretically be buying this, and people are. So tricyclic antidepressants in their therapeutic realm have kind of a pain relieving type effect via the neurologic pathway and the GABA pathway. Tianeptine in particular also does have opioid-like activity. So not only are we treating nerve pain, we're treating pain via the opioid pathway and introducing an antidepressant to patients who may not have depressive symptoms. So when we are purchasing this, we're exposing ourselves to a lot of different substances. We saw this really growing in our construction worker population. So people who do a lot of day laboring, have a lot of pain, who are buying these supplements, finding relief from this for that kind of chronic pain aspect, and then unable to find themselves stopping. What we know of this substance is it does have that opioid-like effect. So we are seeing opioid-like withdrawal symptoms, and patients unable to actually stop this without supportive medications, whether that's buprenorphine or withdrawal comfort medications. The other big thing is, as a dietary supplement, there is no regulation on how much and how frequently someone can purchase this medication, or supplement, I should say. So people are buying these 5 to 10 bottles per day. There's no incentive from dealers or the gas stations to decrease the amount that they are putting into the community because they are making a profit from this. And this is something that is of concern. This does have unintended effects with cessation of use. nitazines or nitazines, depending on how you would like to call them. These are the new and emerging opioid-like substances. So these are originally developed in the 1950s. They never made it out of animal or rat models because of the safety profile. So we know that they have opioid-like effects, but a lot of the subjects, the rats in the original, unfortunately did not survive the study models. So these were basically put onto academic literature and placed on a bookshelf and were not thought about. Unfortunately, with COVID-19 and the shifting drug market, what we saw was the introduction of nitazines into our drug supply, really due to availability. It was easier to synthesize a very potent opioid, just like fentanyl, and bring this across our border than it was to import traditional heroin. The scary part is these were never studied in humans. There was no research in what this looks like. We know they have opioid-like effects. We don't know what their actual intoxication looks like. The data that is available is not pure, so it's not used as what we call a mono substance, so it's never been used by itself. It's always been found contaminated with fentanyl. I was reading an article, again, this past weekend that some formulations of nitazines can be upwards of 25 times more potent than fentanyl. So even tiny quantities of this substance can cause opioid-like overdoses. So ensuring that we are aware of this in our communities and we're able to respond to this quickly. Unfortunately, we're not necessarily looking for this. So again, fentanyl and xylazine are the hot topics. This is a substance that we know is contaminating our supply, but we're not looking for it. So as a substance dealer, if I know that someone is looking into my investigating my ring, are they looking for fentanyl? If I'm not dealing fentanyl or I'm not dealing a supply of fentanyl, I'm more likely to kind of fly under the radar. And we see that in the DEA report. So there was only 94 cases of this actually reported in toxicology in 2022, but that is severely underreported, and we know that. That being said, increasing drug seizures are occurring. Weirdly enough, Tennessee is a high nitazine contaminated area. And so there's a lot of research that's going on in the local harm reduction organizations of Tennessee to kind of give us a better idea of what's occurring. Phenibut is, again, another very old substance developed in the 1960s. Similar to Xanax and Valium, it works as a benzodiazepine, causing kind of dissociative effects and relaxation. It is sold as a supplement, so it is not illegal to possess or sell this within the US borders. However, it's never been reviewed by the FDA. It has no approved medical uses. What concerns me about Phenibut is that it is very easily purchasable online. This is a screenshot of my phone. I will disclose I did not purchase this, but this took me 3 minutes to find a dealer online that I could get this shipped directly to my home. The unfortunate part of using a Xanax-like medication is if I'm treating anxiety and I'm using a lot of this substance, if I were to withdraw, I have that kind of hyperactivity, that hyperstimulation of my nervous system, which not only causes those symptoms of psychosis and hypervigilance, it actually puts me at risk of seizures. If these are occurring without witnesses or without awareness, people are having unexplainable seizure events and could potentially have a death due to that. So I did kind of allude to this. There isn't a lot of hardcore medical data surrounding a lot of these substances. So it's about an informed community. So turning to our different information centers and learning what we can from each other. What does it look like in Michigan versus what does it look like? These are by no means formal platforms, but they are helpful for us as specialists to be able to be aware of what's happening in the community. What are we seeing as medical professionals? What are we seeing as people who use drugs? And how can we make sure that our community is safe? So we are fans of Blue Light here. Blue Light is a great organization. It's kind of similar to Reddit. People can post forums or post what they're seeing in their drug supply. And I have a screenshot of that here. It's very user-friendly. And again, when I was talking about reading articles this weekend, I actually found a couple on Blue Light. So it's definitely what we're turning towards. So in closure of this presentation, wanted to discuss how are we addressing substance use? Well, it's important to note that we're not doing a great job. So only 22% of people 12 and older are actually receiving treatment for opioid use disorder. And there's plenty of reasons for this. Stigma, both from the patient seeking health professionals and health professionals providing medical care to patients. The influence of insurance. Should things be disclosed to insurances? Do I want my insurance provider to know that I'm in substance use disorder treatment? The biggest barrier, which was eliminated in 2020, or beginning of 2023, was the X waiver. So that has been hopeful for a lot of us in the field to expand our treatment options in the future and expand our treatment availability, but we're going to see that in the coming years as well. The other thing that's not mentioned on this slide is medical and nursing education is starting to introduce addiction as part of our core curriculum. So again, that's the long-term solution, but in the immediate term, we need to be better about making care easy, accessible, and harm reductive in nature. Assumption that everyone is very familiar with harm reduction in this call, but effectively what we are doing is kind of supporting patients in their own decision-making, respecting patient autonomy, and safer. So that might look like wound care for patients who are using xylazine. We talked about HIV and hepatitis C with methamphetamine and chemsex use, providing access to harm reductive services, syringe access programs. The biggest thing that Dr. Lane and I advocate for in the medical field is safe and judgment-free environments. So being able to openly discuss what we are battling with our medical providers, and having the medical provider being able to respond appropriately and get that patient the resources that they need if they don't directly offer those themselves. PrEP, which is pre-exposure prophylaxis, is widely available from our work in HIV medicine. This is something that we openly discuss and frequently prescribe in our clinics. We have a couple of different options available. It is important to note that PrEP was not approved for people assigned female at birth. The studies are not inclusive of that demographic. However, it is important to know that PrEP can be prescribed to everyone. It's actually important that we are prescribing it to everyone. Women and those assigned female at birth are one of the highest risk categories and growing. Apretude is a long-acting injectable. This is a nice medication because after we get the loading doses, patients can come back every other month. So it's a lot more user-friendly, and our patients who are unhoused or have challenges accessing care, it's a great option for ensuring that they're covered. And really, this is all supported in data with the hepatitis C as well. A third of young people, so those aged 20 to 30, are infected with hepatitis C and using injection drugs. And treatment is available and it's very effective. We did not have options 10 years ago. We do now, and it doesn't really matter which option you by insurance is good, with a cure rate of about 95%. What we are doing better about is making sure that we don't require abstinence. So historic hepatitis C treatment required the patient to be abstinence from alcohol injection use. What we've learned now is balancing the need for kind of that prophylactic treatment of other individuals who are at risk, for those making high risk sexual behaviors like we discussed earlier, and providing education on risk factors and engaging them in health treatment. Medications for opioid use disorder, I'm just going to kind of breeze through these next slides. We have our mu opioid receptor, and then our full agonist methadone, our blockade, which is naltrexone, and then our middle ground partial agonist, buprenorphine. Methadone is a great tool. It does not cause precipitated withdrawal. It's effectively 1-for-1 with traditional heroin. The downside, if you want to look at it that way, is it is prescribed with a lot more federal oversight and through federally approved clinics. It does require daily dosing for at least a year, and patients often have to earn take-homes. That being said, it is effective. It is great for patients who need heavy engagement with medical facilities and with medical professionals to kind of get those resources connected, and then also to get them resources for housing, mental health. They're kind of an all-encompassing program. Naltrexone is our blocker. Effectively, what this is doing is preventing the binding of opioids at the receptor site. This is great for patients who are already from opioids. It is great also for reducing cravings. So we use this a lot for alcohol use disorder. When we are drinking, it feels good. We get natural opioids or endorphins released into our bloodstream that bind that opioid receptor and cause a release of dopamine, which is that feel-good hormone. That is why we kind of get that positive feedback from drinking. If we are to block that effect, we get decreased cravings. If I'm drinking and not necessarily feeling good because of it, I'm not going to necessarily continue that behavior. Buprenorphine, in and of itself, is a partial agonist of the opioid receptor. It's got a high affinity. The reason we use buprenorphine for MOUD, or medications for opioid use disorder, is because of the partial agonism effect and high affinity causing functional antagonism. So if a patient has buprenorphine in their system, those receptors prefer buprenorphine more than they prefer heroin or fentanyl. So they're effectively protected against those substances when they have buprenorphine in their system at a therapeutic blockade level. It also slowly dissociates from that receptor, so patients don't have withdrawal symptoms when they are coming off buprenorphine. So if we have patients in long recovery who eventually want to transition off any sort of medication, it's a great gradual tapering option and effective in that sense. It does come in a long-acting injectable formulation. I'm not going to go extensively on this, but I want to talk about it. The kind of red dashed lines on our side are the saturation points in our brain. We have two different options and two different doses here, 300 and 100 milligrams. Effectively, we are keeping their brain receptor sites saturated with that buprenorphine to provide that functional antagonism or protective effects, while also meeting their cravings and dependency on opioids.
We might have to breeze through the rest of them, so we have at least a couple minutes for a question. I'm sorry.
That's okay. Narcan, please carry it. It's great. Be aware of your Good Samaritan laws. The biggest thing is when you administer it, roll the patient on their side, protect their airway, they may vomit. The data shows that we're putting Narcan into our community and we are saving lives by opioid reversals. Low barrier care. Turns out when patients need care, they need it now. We need to have treatment that's available and available same day. What questions?
I think I answered some of them in the chat, but if people want further clarifications, feel free.
Yes, thank you. Oh, sorry.
I was going to say, somebody mentioned they have a Narcan distribution box. That's awesome. This is a medication of community benefit, meaning anybody can hand it to anybody. You don't need to prescribe it to an individual. So you can have those distribution box.
Thank you all so much for you all's presentation. It was like jam-packed with great, useful information. I truly wish we had more time. So I'll go through one question, and then also, if you don't mind putting contact information in the chat, so maybe if people have additional questions, they can reach out to you all. But hopping into our first question, given the evolving nature of the illicit drug market, how can communities and organizations proactively work together to prevent the spread of new dangerous substances?
Dan, do you want to take that one?
Yeah, so a lot of what we're doing in our community is partnering with kind of all of the different aspects that people are interacting with systems, whether that's the legal system, whether that is the harm reduction organizations. It's about going in and making sure that we have lines of communication that are open. What's actually very helpful is having an understanding. So what do I, as a health professional, what do my patients experience in the justice system? What is their involvement? What can I do to inform the justice system about what it looks like to treat methamphetamine and how difficult it is? What does it look like to get patients who are post-incarceration to methadone clinics or buprenorphine clinics? What's user-friendly for the patient? Having those communications open, partnering with our harm reduction organizations to know what's happening in our drug supply. They do a lot of drug testing. They can tell us, hey, xylazine is in your current supply right now. or we're seeing the fentanyl contamination being 40% and now it's up to 60%. So what do I need to do to respond quickly to kind of changing community needs?
Yeah, thank you so much. And I appreciate that systemic perspective and being able to collaborate and get information from, all people that work in the community. I know we are out of time, but again, thank you all so much. After the webinar, you all should be able to complete a survey. If you have any follow-up questions for Dr. Lane or Dan, please feel free to use their emails. And I literally can't thank you all enough. This was so informative. And I hope all of our guests have a great rest of their Mondays. And happy holidays.
Thanks, everybody. Happy holidays.